So today, hello everyone, Helen-Maria Vasiliadis, professor at the Faculty of Medicine and Health Sciences, so in the Department of Community Health Sciences. So we do have a lot of public health approach to our training with regards to graduate students and our faculty. So today I will be presenting on the role of surveillance and evaluation in the health and social services and how it can inform evidence-based policy. So the plan, I'll present very briefly the mental health action plans in Quebec, our health system performance framework, which we use in Canada, the different Canadian sources of system surveillance, and why I was here invited specifically to present on the processes used in evaluation of health and social services, and I'll go into detail with regards to the guiding principles and criteria used by MERRPS, and I'll give two case examples, one on equitable access to psychotherapy, but we just discussed a little bit of that, but maybe I'll give a background as to the work that was done behind that, too, from a researcher's perspective. And also the second case, if we have time, the optimal service trajectory for ADHD. So in 2004 to 2006, there was a federal commission that really put a spotlight on mental health, transforming the mental health system and mental illness. At the same time, Quebec published its mental health action plan with a plan with over 5 years, and the main outcome was to increase the effectiveness of the mental health system by offering accessible, appropriate, and quality mental health services in primary care that would meet the mental health needs of the population. And how to do this is that they but they called rather for a hierarchical reorganization of first, second, and third line mental and health and social services. So just briefly, first line, second line, and third line. So obviously we increased complexity of needs, and the focus was that, this is a continuum of services, the main focus was that 70% of all mental health care should be in primary care. So primary care needed to cover 70% of the population's mental health needs. And what we have here is that it was structured as first-line care, so people would get referred by their psychologists, by physicians, by family members, crisis services. People themselves could refer themselves to a general point of service that would then be evaluated, and usually a nurse would be there for the intake and refer the patient to whether that person needed to be still kept in primary care, or if they needed to be referred to second-line specialized or specific psychiatric services, and then referred to third-line services where they would be offered only in hospital university centers. So basically here you have from first line to second line to third line. Once the patient is stable, we want them always to go back to first line. Emergency departments are there as support as well as hospitalizations. So following that action plan, we had a second action plan, 2015 to 2020. It's coming to an end. And here, this action plan really acknowledged the improvement and the great work that was done by reorganizing the health system, but that we really needed to make it even better with a greater focus now on promote respect for the rights of citizens with mental health problems, provide care and services adapted to young people, so really from birth to adulthood, a life course approach to health service use and care, implement clinical and management practices to improve care, and continuously improve the quality and delivery of mental health care and services. So here the key word is continuously. And for the first time, and not for the first time, but here in this mental health action plan, ministerial standards were really included in the action plan. So, and these are just some of them. There's about 35 of them. But with regards to services, they want to keep the hierarchy of services. The level of services offered should be determined not by the diagnosis, but by the systems, so giving timely and accurate services to people as a function of their needs at that time. Here are just some indicators for ACT teams, case management teams, psychiatric beds, but they also gave with regard, indicators with regards to maximum delays. Maximum delays, for instance, for example, for first episode psychosis would be 24 hours, 7 days for first episode psychosis, but in a somewhat stable state, etc. So these are just some indicators that were included. In Canada, we have the Mental Health Commission of Canada, which looks at stigma and also really helps also researchers and also producing policy reports. And they had organized a group of experts to focus on a mental health performance indicator framework. And 50 experts across Canada were consulted on this work. I was one of them. And we're still in discussions. It's a work in progress. But it's interesting and important to know that we want to really focus on mental health specific indicators. So what we have right now in Canada is this conceptual framework, if you will, for measuring the performance of the health system. And this was published from the Canadian Institutes of Health Information, which is an internationally recognized framework based on WHO and OECD work, previous work. So basically, in this adapted framework, we see how the different quadrants are interrelated. So we have health system outcomes, triple aim objectives for every health system: improve the health status and well-being of Canadians here, improve health system responsiveness, and improve value for money. Proximal to that is the health system outputs, and this is where it's really in the middle, access to comprehensive, high-quality health services. They should be person-centered, safe, appropriate and effective, and efficiently delivered. Equity is transversal, transversal, so it captures all of it, and this quite an important dimension that is looked at. We have the social determinants of health, which was also underlined as an important quadrant to look at. And at the left-hand side, the health system inputs and characteristics, which is efficient allocation of resources, money, professionals, human resources, adjustment to population health needs, and health system innovation and learning capacity. Yeah, Hannah, you were blocking. So here are just some examples of key indicators that we use. For instance, for appropriateness, do health services rendered correspond to the mental health needs of the population? Are they evidence-based? Do they follow clinical guidelines? Some of the measures that we could be able to assess this is to ascertain if treatments are based on national clinical guidelines for mental disorders. Are mental disorders treated in primary care? Efficacy. To what extent do health services work at improving health or have an impact on the incidence of disease? So we look at mortality by suicide, incidence prevalence of mental disorders, changes in self-reported mental and overall health, quality of life indicators, safety, minimize all risks associated with health service and intervention. We can look at inappropriate prescriptions, for instance, the MERRPS, and also patient-centered patient experience indicators, which are very important. We have health system indicators. We also need to consider patient perspectives and patient indicators, which is not usually, and this is one of the challenges, when you want to bring patient perspectives into measurement frameworks, you need to have that data. And this is one of the interesting things in Canada that we have, is that we have administrative data that we can link to health survey data, which is yields a very rich data source. And this is how you can actually measure and evaluate unmet needs, and also from their perspective, did they get adequate services, appropriate care given their specific symptoms. And that's it. So I think we've all seen efficiency today. We're good with that. So just for, I think it's running out of battery. So. Oh, there we go. I had removed that this slide, but then I removed it during the lunchtime because a lot of people were presenting data on costs. And the framework, and I think somebody mentioned, how do we put importance on mental health? And I think in Canada, the Mental Health Commission of Canada has really put a focus, and they really work very hard in this point. Their mandate's obviously on making the case for investing in mental health. So the fact that we say it's not only severe mentally persistent ill patients, we do have common mental disorders. 1 in 5 people do have a common mental disorder, or at least once in their lifetime. And that makes it a little bit more realistic for people to understand that somebody in their family might have a mental, or be affected by a mental illness at least once in their lifetime. So in Canada here, what they presented, numbers speak better than words sometimes. So number of people in Canada with mental illness by age group, and they really showed how there would be an increase in mental illnesses in 30 years. So they compared 2011 to 2041, and we do see significant increases. So these represent in prevalence, prevalences 12% are due to depression and anxiety, 6% substance use and dependence disorders, and 2% dementia. And what was interesting to me here, and I'm an epidemiologist, I'm not a health economist, but I do health economics, is this figure, the bottom figure. We always look at what does it cost, so past year costs, and the costs are in billions, but they presented it as what are the cumulative costs. So the cumulative cost of mental illness in Canada, and this includes not only health system costs, but loss of productivity and disability, that would reach $2.5 trillion. So when you hear $2.5 trillion, the way this figure is presented, and this is a policy brief that is published for everyone to see, I think the general population says, I think everybody can understand what $2.5 trillion is. And it's like, I really don't understand that number. So that's how you also get, in that respect, some interest in why it is important to invest in mental health. This quote I took from a leading researcher that is a Quebec researcher who was a specialist in the organization of health services. And so basically what, I'll just read it, evaluating efficiency is an integral part of the decision-making process of health decision makers, hence the importance of providing evidence to support the development of appropriate health policies for better delivery of health services and adequate allocation of resources. So here, again, the key thing that comes out is efficiency is important for the decision-making process, and what are the tools for this? The tools for this is evidence. And many have presented and done research in this field, in this policy making world, and this is just some statements that were summarized by the Bridging the Gap, the role of monitoring and evaluation of evidence-based policy making from UNICEF. And here, I found this was very well summarized. So using timely and accurate data from integrated monitoring and evaluation systems and strong evidence can inform policy making by showing what the problem is. This will help recognize a policy issue. What's the problem? What may be for that politician the next vote that he can capture, his next priority, his next mandate? Inform the design and choice of policy that will allow its analysis. Evidence can also, and data, can also allow future predictions on the short and long-term outcomes. And this type of data help us in model parameter estimates, also forecasting models, and also extrapolations. Allow the monitoring of policy implementation on expected results, and evaluating policy impact along the line, or after it has been implemented. So for the different disease or surveillance systems, here is an example that I think is a great one. In Canada, we have the Canadian Chronic Disease Surveillance System, which is a collaborative network of provincial and territorial chronic disease surveillance systems that all report back, they have agreed to all report back to the federal government, the Public Health Agency, it's not the Public Health Agency of Canada. And what it does here is that it identifies chronic disease cases from provincial and territorial administrative health database databases, which include physician billing claims, hospital discharge abstract records. So case definitions here, and I think it was mentioned earlier, are based on ICD-9 and ICD-10 codes. We mentioned in the province of Quebec, the province in Canada, each province have their own health systems and the way they bill even. So there was work that was done, and that was supported by the Public Health Agency of Canada, which held working team mental illness working team groups on this for this disease, where we took some time, and we took a couple of years, and I was part of defining or validating the ICD-9 and ICD-10 codes used in each province. So with that validity exercise, we were able to then pursue and that's it. So we did that validation exercise, and that permitted us to go ahead and continue on producing on data on mental health illnesses. So here are just some examples of the type of data that the report presents. So here we can see age standardized annual prevalence of the use of health services among people aged 20 years and over from 1996 to 2007. So you can see time trends here. Here you have another way where the data is presented by provinces, so provinces can actually compare themselves to it. And what is interesting, so these are 2009-2010 data, policymakers and researchers do not need to wait for these famous reports to come out every 5 years. So what they have on their website is that you can go onto the website, click on what you want to see, and this actually, I did the exercise and I was able to capture this picture exactly like that, and where it shows where we are at 2015 fiscal year, latest available data. So it really is interesting with regards to having timely, relevant data to inform a problem. I also want to mention the Health and Welfare Commissioner in Canada, in Quebec, not in Canada, we're in the government of Quebec now, who, the mission of the commission is to provide perspective for public debate and government decision-making that will contribute to enhancing the health and welfare of women and men in Quebec. And their mandate, they have 4 mandates. It's to appraise the outcomes achieved by the health and social services system. So they look at structures, they look at resources, the services it provides, and the outcomes. It consults with citizens, experts, different stakeholders, and it informs the Minister of Health and Social Services, the National Assembly, and it can also hold public hearings. And it makes recommendations to the Minister of Health and Social Services for any changes that should be made. What is interesting and why I mentioned this, because when we had our work on the Mental Health Performance Indicators framework, Quebec was applauded from the rest of the provinces because of how important, how well it utilizes health administrative data, health survey data, and all its institutes in producing health performance indicators. In this report, so it's not only performance that it can define performance measures, but in the future can also help us inform better frameworks and more specific frameworks for mental health. So here, this report presented 109 indicators, and they were able to compare Quebec to, they made international comparisons with the WHO and OECD, and they also were able to do provincial comparisons, and they were also able to do regional comparisons. And this is by using also information from the National Institute of Public Health, databases hosted by the Quebec Ministry of Health, Quebec's Institute of Statistics, Statistics Canada, and also other professional associations, and Statistics Canada's Canadian Community Health Surveys, which are close to surveys on 40,000 people, which represent approximately 8 to 10% of the Canadian population, which is 38 million people. So here are just a couple of the indicators that the report presented. So you have prevalence of mental disorders, non-medical determinants and protective factors, efficiency, financial capabilities, human and material capabilities, so number of psychiatrists per 100,000 population. There's about 13 per 100,000 population in Quebec. Number of psychologists, there's about 59 per 100,000 psychologists. Number of social workers, and also what's interesting, again, from the patient perspective, adjustment to the needs of the population. Proportion of the population reporting unmet mental health needs. So now, this was for the surveillance, evidence from surveillance systems, and now evaluation of the health and social services system, and this is where I come to ENES. So it was mentioned before the challenges, the challenges of including also social services in health. And one of the issues was that it would be important to be able to use the same criteria to compare in these health technology assessments when we're evaluating interventions in psychosocial services and mental health, that medications, interventions, and technologies were compared using the same criteria. And this would be great for ENES because this would imply also that ENES would adopt a favorable position to collective choices focused on creation of value for the benefit of users and patients and for the entire population. It would participate in the evolution of evaluative practices, which is great, since its mandate is clinical excellence, and it would support also responsibly innovation and sustainable health and services in response to decision makers at all levels. So in its triple aim objective, which is clinical dimension, population dimension, economic dimension, again, always considering the organizational and socio-political context of the time, ENES proposed 5 different approaches or principles that would guide them in their evaluations. The first one is object relevance and assessment methods, knowledge integration, reflexive multicriteria deliberation, fair and reasonable recommendations, and supporting creation of value and reevaluation. Now, to be able to evaluate the different key dimensions, ENES proposed criteria within each one which were in accordance with the guiding principles. So for clinical dimension, criteria would be clinical efficacy, clinical adverse effects, impact on quality of life, patient acceptability, which is very important, type of clinical benefit. Population dimension, severity of the condition, population size, extent of unmet needs, ability to reach the entire target population, and social priorities. Does it have to do with vulnerable populations? Economic dimension, cost of acquisition, cost in health and social service system resources, cost to users, which is very important. Societal cost, loss of productivity, opportunity cost, environmental impact. In the mental health services, we know that loss of productivity is an important component, where 40% of the costs are due to loss of productivity. Organizational considerations, system capacity for optimal use and implementation. This includes infrastructure, are there enough human resources and competencies available, legislation and risk management, and does it align with the mandate of the health and social services system, which is very important. And sociopolitical considerations, historical, political, cultural context, and stakeholders' visions, and finally the clinical and economic goals combined, which is the cost-effectiveness ratio. So here are the criteria that they use for all interventions, whether it's a technology, a psychosocial program, or medication. So relevance of interventions and modes of evaluation. So the first thing is that there should be a decision on the admissibility and evaluability of the object to ENES. Not everything that comes to ENES, that ENES will evaluate it. So how do they do this? So they consider whether the intervention has a great potential to change the health system. Is the value great enough to be able to also invest all the resources of ENES also to evaluate this intervention? Systematically analyze evaluation challenges. Sometimes there's very sparse data, the mechanisms of actions are not very well known, uncertainty surrounding the health system resources, and this is where ENES needs to put a lot of resources and to put modalities are put in place for adaptive evaluations. And this is also where experts come also to weigh in. So this is where they mobilize expertise which is required according to the evaluation of challenges, and back to what was presented earlier. Yes, when Ines calls researchers, there's no question. People put things aside for Ines. Choosing appropriate deadlines, optimizing methods and processes for mobilizing knowledge, and deliberative process to take into account challenges raised in the evaluation. Mobilizing and integration knowledge. Here the aim is to have informed deliberations and integrated decision-making as to the value of the intervention and support knowledge transfer for decision makers and users. And how do we do this? How does Ines do this? By looking at the scientific literature, grade literature, ethics. They also do their own analyses given the data sets that are available to them, where they do look at health administrative data, medical records. They also look at data when required from the education, from the justice systems, the economic development ministries. They also consult with relevant stakeholders, patients, clinicians, managers, and lawyers. And they also look at different types of studies, whether it be quantitative, qualitative, or mixed methods. And always throughout, quality assessment of all this literature is always done to ascertain methodological rigor, quality of the data, transparency of the methods, and also independence of the processes and people that are being engaged or that have published the article. Principle 3, multi-criteria deliberative approach. And here the aim is to have a most diverse possible group of people that will actually weigh the arguments in favor of the intervention or against the intervention. And this approach is very interesting because it is structured by a deliberation guide that includes knowledge according to the criteria that we saw, derived from the triple aim dimensions. So that really helps people understand each key element. So a deliberative body is mandated to bring together relevant perspectives. So they bring in citizens, system users, clinicians, managers, program directors, ethicists, when needed, scientists, experts, to ascertain methodologies, and even lawyers. The deliberative grid creates spaces conductive for group reflection. It's important that each member around the table also understands the meaning and relevance of each criteria, because if they don't understand it, then what kind of opinion they might have. So enough effort is put into this, always, however, respecting each person's expertise. Deliberation on the overall value is based on the data and findings for each criteria, but they do weigh, though, the importance of the different criteria. And recommendations are put in place, are emitted, and when appropriate, terms and conditions of their implementation is provided. Principle 4, which is fair and reasonable recommendations. How they do this is that they state the argument by explaining all key elements to this group. And for each criteria, the group needs to state the contributions, whether it's positive, neutral, or negative. And as I mentioned earlier, when required, it will also identify the terms and conditions of the recommendation that are feasible, clear, and precise. And this is important to allow for the intervention to produce its full value in the real-world setting. Because if we do not put a favorable environment in place for the intervention to have its potential value, then there's no point in going through and investing. So for example, the training of personnel, if that is needed, even patient education, conditions favoring the aptitude of patients taking care of their own health, for instance. So based on the levels of risks associated with different uncertainties, mitigating risk conditions are described as achievable, clear, and precise. And the administrative burden must remain acceptable for the health and social services at all times. So when the contributions of the intervention as a whole are considered negative, the recommendation is refuse public financing, withdraw the technology or establish modes of intervention, and no longer ensure financing. This is where the reevaluation of Ines comes into play also. And this is just a hypothetical example that was very graciously given to me by Dr. Roy, who is the Director of the Clinical Governance, Vice President of the clinical governance of your work. And this is just an example, for instance. So for deliberation, you see that all the criteria are presented for everyone, this deliberative group. And for each criteria, they are able to state whether it is negative, positive, and promising, for instance. So here in this, we'll just take the first example, increase in efficacy after 12 months versus current practice deemed substantial. And this example was an intensive integrated multidisciplinary intervention of a high-tech web platform to reinforce the strengths of children with multiple development disorders. So here, was there clinical improvement? Here is deemed substantial because the improvement was more than 30%, and therefore the recommendation was positive and promising. So this is one approach. And principle 5, support the creation of value and reevaluation, ensure adequate knowledge transfer to promote the uptake and implementation of its guidelines, and support the optimal use of technologies. Specify measures to evaluate the performance of care and services and arrangements for implementation and monitoring of performance indicators. So what would be important to evaluate, to measure system performance, maintain recommendations up to date, and disseminate them to clinicians and stakeholders. We saw the different products that INES has on their website and provides to clinicians. Make use of different actors in the health and social services system, evaluation units, partnerships that were mentioned, and also consultations, themes in future, for instance, triennial activity plans. INES is very good. Before I was on the board of directors, I was a member of the Committee on Excellence of Mental Health, Young Adults and Families. And what was very interesting here is that you have a group of experts that are being presented what is being developed as, and it's not necessarily for a health technology assessment, but priorities or to address a portrait or to describe the portrait of a health system issue. And you have a number of experts, criminologists, ethicists, epidemiologists, clinicians, primary care physicians, psychiatrists, all assessing the evidence and making comments to this. So all of this work that goes behind and all of the expertise that is mobilized in INES's products is quite important and also quite enriching, which also, I think, not only from a researcher perspective, from a population also perspective, that's when in this transparency where you have the population trusting INES or the products that come out of this organization, which is an arm of the Quebec government. And finally, promote and support the ongoing development of evaluations and reevaluations in the health and social services, including the development of new frameworks for improving practices and also networks. Do I have time for my case studies? Maybe one?
Yeah, I think one of the
So my first case study is on equitable access to psychotherapy services in Quebec. So one of the recommendations of the health commissioner was that, because like we said, the commissioner also recommends. One of the conclusions was that, and it was mentioned earlier, long waiting lists, lack of coordination and responsiveness to patient mental health needs, and inequity in access to services such as psychotherapy. And the recommendation, and I took it from there, enlarge public insured services in mental health by ensuring an equitable access to psychotherapy. This was the recommendation, and this report was in 2013. What's my next slide? Because I've removed slides. So before that, I'd like to say, oh, I went too far. He wants me to finish. It's the end of the day. Everybody's tired. No,
is it redundant? Should I move it?
No, that's fine now. So here I mentioned, so after that report, the Mental Health Directorate of the Ministry of Health and Social Services entrusts INES with the following 3 mandates. Evaluate the effectiveness and cost of psychotherapy compared to pharmacological treatments, inventory and analyze different organizational models enabling accessibility to psychotherapy, and evaluate the financial impact of coverage of more extensive psychotherapy services in the basket of insured services under our Medicare. Prior to that, though, one has to mention, this is from the researcher's perspective and the interaction I've had with policymakers, was that in 2009, I had received a grant from the federal funding organization, the Canadian Institutes of Health Research, which allowed me to go to the United Kingdom and Australia to visit key senior researchers and policymakers that had helped or had facilitated to integrate psychotherapy as part of their medical service, Medicare services in Australia and the NHS in the UK. And obviously I'm talking about the IAPT program and the Better Access and the Better Outcomes program in Australia. So following those two interviews, not two interviews, I met with 10 different people in each side of the world, and I came back to Canada. Now this was during my postdoc. I had 2010, I had 2-day meetings with the Mental Health Commission of Canada, the Institute of Health Economics, the Government of Quebec, and also the Ministry of Quebec was there, because he was one of the collaborators in my research grant. We also had family physicians, psychiatrists, and also the Order of Psychologists of Quebec and the Order of Psychologists of Canada. So with this committee, after presenting 2-day meetings and all the implementation processes and what at that time, the difficulties they had in implementing the programs, it was agreed during that meeting that I would go ahead and submit another CIHR grant, another federal grant for money, but that I didn't need to replicate another cost-effectiveness study of psychotherapy. That, they did not want that. What the policymakers wanted to know, how much would it cost in Quebec, for instance, and in Canada, if psychological services were covered under the basket of services. And that this would actually help the decision makers when in 5 years' time we spoke about the health transition funds. The federal government gives money to the provinces every so often. And they were going to receive $5 billion, and this happened in 2017. So this is back in 2011 now, 2010, 2011. So they wanted to know, is it going to work? And how much is it going to cost? Because we know that we're getting money in 4 or 5 years. We didn't know the amount, but no, at that time we did know the amount. It was $5 billion. So with this advisory committee of policymakers, decision makers, and leading health economists, I went ahead and submitted the proposal and got the money. Not the first shot, the second shot. The economic modeling needed to be fine-tuned. So we got the money. And following this, so this is now at around, in 2012. So at the same time, what is interesting here, so as a researcher, the director of the Ministry of Health is on my advisory board. I'm keeping him informed, not daily, but every 6 months, 8 months, there's a key outcome deliverable that I need to bother him with. I'll just send him something. No email, no hi, just hello, here's something that you may be interested in. So all of this in mind, Ines continues with their work. Ines in 2015 creates this committee where, so it's the Ines work group, which includes also an advisory board, which includes clinicians, economists, administrators, and community organizations, and also external members, which were mostly psychologists for these two reports, to validate the methodology that was used in the evaluation and content of the report. And what they did here was that they carried out a review of the literature. They did a review of literature reviews. Quality according to Amstar to compare psychotherapy with pharmacotherapy in the treatment of adults with anxiety and depressive disorders. And part 2 of the publication was the analysis of terms and conditions for access to psychotherapy services. So here, a narrative literature review is performed with a comparative analysis of different organizations and how different countries integrated it in increased or improved access to psychotherapy within their own organizations. So they looked at different databases in the grey literature. Part 3, which was supposed to be the economic evaluation, was published in January 2018. And in part 3, Ines was in discussions because they had to do the economic evaluation, but at the same time, you're having also our research program that's going ahead, and you have Health Quality Ontario that's going ahead with their own evaluation. So what Ines did in this report, they did not carry out their own evaluation because they understood that there was no, at the time, and it was mentioned previously, there was no Canadian data on the cost effectiveness of, there was one in the UK, there was the Australians didn't come out with a cost effectiveness paper, but it seemed to be effective. So what they did here is that they presented data on the IAPT program, the Better Access program, and the ATAPS program. They analyzed the literature to see if there was any new literature that was out there that they needed to include in this update. And what they showed was that the data from the English and Australian programs also indicate that it pays to invest in psychological interventions, including psychotherapy. So this was one of the conclusions here. At the same time, they also mentioned 2 Canadian studies at that time. Economic modeling suggests that improved access to psychotherapy for depression and anxiety is cost effective. And here, for every $1 invested, there would be a return of $2. So this was the Canadian data that was included in this report. So here was, and it's not to look at the data, but this was from our study, the Canadian Institutes of Health Research study, and this was a modeling, a study of where we used discrete event simulation modeling over a 40-year period. And it shows that increasing access to psychological services is dominant even in the sensitivity analysis where higher limits were considered. So it improved qualities and it was always reducing costs. And at the same time, there was also Health Quality Ontario, which is the also Health Technology Assessment Agency, where they also had done a different type of economic evaluation, but over only a 5-year period, and where they showed that ICERs, so a group CBT, was associated, as opposed to usual care, was associated with, sorry, my eyes are going like this now. So the quality for that was $3,700 Canadian. The ICER for individual CBT was $43,000 per quality gained. And here they also presented that public funding for structured psychotherapy would result in approximately $11 million to $529 million per year for the next 5 years. In our Quebec study, we had estimated it at about $124 million when considering the Australian model, where a GP would refer the patients to the psychologist and they would have, on average, 68 sessions over the year. So the implications of that, so what are the implications of covering psychological services as part of Medicare in a public managed health system as is Canada? So you need to, and this is important for policymakers, 4 questions that need to be addressed is access, who will get treatment? Here, Ines proposed all age groups. Equity, type of services offered, and which are the ones cost effective. So CBT was the most studied. However, other therapies have also shown effectiveness, and many patients also prefer different, and also psychologists prefer different methods also, such as interpersonal therapies and others. So professional and patient choice are a must here. Patient-centered care is the serving meeting individual mental health needs. So here, what Quebec suggested was a low-intensity, high-intensity through stepped care trajectory integrated in primary care, that famous hierarchical reorganization that I presented at the beginning. So it's not the low-intensity, high-intensity as the IAPT program is, but it's really to go from first line to second line. And our health outcomes improved at a sustainable cost. Apart from our studies, the WHO had also shown investments up to for every $1 invested, a $5.3 return for depression and $4 for anxiety. So following this, and this is what has been happening in Canada, in Quebec, following all this work. In Quebec, December 3rd, 2017, Health Minister announces an investment of $35 million to launch a first public psychotherapy program in Quebec, the the media was all over. Quebec, May 7, 2018, Minister announces the launch of a pilot phase of the new Quebec psychotherapy program for mental disorders, and this is in line with, we had suggested in our study, taking the Australian perspective. This was not the case here, so the government decided to do 2 pilot phases where they would test the guidelines for depression in children and adolescents and guidelines for adults with generalized anxiety disorders and panic disorders. And what they had done here, the testing was to see, they had translated the NICE guidelines into French and to see how effective this was. And in Quebec, Quebec. Sometimes I put Quebec to differentiate between Canada and Quebec. Quebec here, May 13, 2019, the new health minister announces a step care approach, hierarchy of services to improve service trajectory and combat waiting lists. And their aim is that by 2020, that all would have access to psychological services. So deployment has been in fall, and INES has been mandated to produce and update the French Clinical National Guidelines in collaboration with the UK's NICE. I'll stop here. You don't want to hear about ADHD? No?
But I'll share your presentation with the speakers, so it's in there.
Okay.
Thank you very much for keeping an eye on time.
Good. Thank you very much.
And here, whoever wants to share, if you share the presentation, just here, I'm just summarizing the factors influencing the policy making process. And one that was actually mentioned from, and I'll finish with that, from the Netherlands was the uptake of evidence is facilitated when the implementation is reversible if needed. And that was quite interesting also. So thank you.